I welcome all you to the fourth edition of the TMC Meteorologs, and it's a pleasure to introduce Dr. Sivakumar Ramachandran, and he's an alumni of TMC from 1986, and he did his MD from Stanley Medical College, and he is a gold medalist and a Jiawuddin Award prize winner in his undergraduate days, and in MGR University, and a gold medalist in Stanley Medical College as well. He moved to UK in 1997, and for the past 15 years or so, he has been the clinical lead for stroke services in England. And his clinical team has consistently ranked in the top 10% of the stroke unit. And he has been on the clinical advisory of East of England, advisory group clinical lead. And he has won several grants and published close to 25 papers. And his passion is mentoring people and teaching and research. So, without much ado, I would welcome Dr. Ramchandran Shivkumar to deliver his lecture for us. Thank you, sir.
Good evening, everyone. Thanks, Venkatesh, for your kind introduction. I think at the outset, I'd like to congratulate our seniors for starting this initiative. I think this is a very, very good one. And this is the fourth one in the series, I think. And it started with Dr. Morali. It was a fantastic lecture, and subsequently Dr. Ravi and Dr. Sujata Madam. I think it's always very difficult to give a talk on a very broad topic like AI. And I think it's going to be quite challenging for me, but I will try to do my best. Some of you might be wondering what these pictures are. The top second one is my primary school, Sacred Heart Convent. Some of you know in Tanjavur, it's in the Convent Road. And the next two on the top is this lovely atrium. This is my secondary school, Kalyana KHSS, Kalyana Sundaramaya Secondary School. It's got this wonderful balconies in which we are not allowed to get on because it's quite bit flimsy and so on. But it's a very beautiful site. And then moving to the bottom left, I don't need to tell you. And the next one is the lovely greenery of Tanjavur, which I'm always very proud about. And as some of you may not know, it can cater to the requirements of entire South India on its own in terms of the paddy requirements. And the next is Royal College of Physicians. And last but not the least is this fantastic walled city called Colchester. It is ironical that Colchester and Tanjore are probably the two of the oldest towns or cities in India and UK, respectively. Colchester was the capital of United Kingdom much before London. For everything in UK really started in Colchester, where I am currently based. And some of these are managed, damage, I mean, but it still stands as a history of for the United Kingdom. I'm just moving to the next slide. For just a bit of a disclaimers, I'm not going to read through that. Mainly, it's an unpaid talk. Some of the material I have used are copyright material, but it should constitute fair use. Very importantly, these are my views and not that of my employer or NHS. Some disclosures: I have received grants from East of England Stroke Clinical Advisory Group, and I also received speaker fees from pharmaceutical companies, but I don't think it has got any direct relevance to the talk, and certainly no relevance whatsoever for the AI system, which I'll be talking about as I use at least two of the AI systems currently in use. Why did I choose this topic? Am I an expert in AI or engineering? Certainly. Am I an expert coder? Certainly no. Am I an enthusiast? Probably yes. But certainly I would like to say I'm a very early adopter. Around COVID time, I felt that there was a clear need to use the existing AI, and it was quite challenging on my part as clinical lead to implement this in our hospital. There was a lot of resistance, but I believed in the technology. and subsequently in our region, since last year, almost all hospitals are using the system what we are using. For I think I have a lot of enthusiasm for AI, but we will be discussing in this talk the pitfalls as well. I'll be doing a great injustice to AI if I do not mention about chess, because AI looked at the chess as the crucible. For AI wanted to conquer a chess first, and it succeeded. And then this particular practice then was subsequently extended to different disciplines. I just want to flash a picture. I'm not going to describe what it, what is the, when was it taken and what was the significance at this stage of my talk, but please feel free to type in any about whatever information you know about this picture. But I think this picture tells a lot about AI, and if please feel free to type in and engage in this presentation. For what I'll be covering is about evolution of AI, introduction to AI, its clinical applications, its challenges, and future of AI. As I already mentioned, it's a very vast ocean, and I don't think I'll be able to cover even not 1% of this topic. And probably AI will do a much better job. But what I intend to do is to signpost you to areas where you can ask AI, I suppose, and then it will tell. Therefore, I think it's just a bird's eye view of the topic. So can I ask you, who is this person and what was one of his greatest questions? Does anyone know? Okay. His greatest question was, he asked the question, can machines think? In 1950. Just, I repeat, in 1950. This is Alan Turing, one of the greatest mathematicians and probably considered to be one of the fathers of AI. He's from Manchester, and the statue is in Manchester still. He's an extraordinary genius, as you will find during the discussion. Well, what did he do? For in 1950, he wrote a landmark paper on an imitation game. You might have heard about a movie called Imitation Game. It's worth watching, but I have not watched it myself, but I've read this paper. This is probably one of the most extraordinary papers in the scientific field I would say I've ever read, and probably considered one of the greatest papers written by anybody in any field for that matter. In this paper, he basically starts with, I propose a question, can machines think? And he just goes on to discuss his thought processes. For in this paper, he introduces something called as a Turing test. I just remind you again, this was in 1950. For he proposes his machine to act, it was basically a machine versus human being, and an interrogator has to find out whether that machine is actually a machine or a human being. If the machine makes the interrogator mistakes it as a human 30% of the time, the machine has won. The Turing test has been passed. In other words, machine can trick a human being to assume it as a human brain. For this is the Turing test. This is the yardstick which was used at the time, though this was now considered to be a bit controversial, but it still stands valid. And he went on to say in that paper, an extraordinary piece of prediction. By the turn of the century, one would be able to speak of machines thinking of um, without being contradicted. And in that paper, as an extraordinary genius would do, he could actually anticipate what are the things people would use as an objections, what objections he would be thinking of in this situation. He proposed around 8 or 9 objections, and one of the objections is a theological objection. Other one is that means God alone can create a soul. Completely pessimistic, that means it's in the sand objection. The consequences would be disastrous. Let's hope that machine will not establish itself. A mathematical objection. Computers have got limits, and we can't. I don't think the computers will become ever that strong. And he also objected that say machines cannot originate anything. It can only be subservient. It cannot be compared with our nervous system. And most importantly, is can a machine really feel? Still, this has not been conquered. But as I mentioned, is an extraordinary objections, and most of which have been conquered. Then he also went on to say machines will eventually compete in all purely intellectual areas. But he suggested where should the engineers be working on? And he suggested very abstract activity like chess and understand and speak English. Boy, he got it absolutely spot on. We got a generative AI, we got chat GPT, all sorts of things which can understand and speak our English. And as I mentioned earlier, chess has already been conquered, almost conquered by machine learning. And he also went on to say that both approaches should be tried. Just give me a second. Yeah, that's fine. For if people are interested in knowing what happened to Turing, I'm not going to say that. Please feel free to go and check the internet. It's a bit controversial and it's very, very sad. He died at the age of 44. The term AI was introduced by somebody called John McCarthy, and it was defined as computer programs that engage in tasks currently more satisfactorily performed by human beings because they require a high level of mental process such as perceptual learning, memory organization, and critical reasoning. These are the 4 main components: learning, reasoning, self-correction, and creativity. What is the timeline of AI? That is, in 1950s to 1970, it's a simple machine rule-based problem solving like a calculator. Between 1980s to 90s, it's learning without programming. And from 2000 onwards, it's sophisticated stuff. But can you spot anything? Any gaps here? There are 2 gaps in this. It's called AI winter, first AI winter and second AI winter. And the scientists hope that there won't be any third AI winter, because first AI winter, 74 to 1980, the computing powers could not keep pace. And then the second AI desktop computers started to outperform AI platforms. But as with any major scientific breakthrough, a sensational milestone has to happen. And does anyone know what happened in 1997? Please feel free to type in. This raised the profile of AI, made the world notice the impact of AI. It was a sensational demonstration of machine versus brain.
Was it the chess championship?
Yeah, these 3 pictures tell you the passion in which Garry Kasparov represented our humanity. For he took it so seriously, and you could see the disappointment when he lost the 6th game. At the end of 5 games, the score was tied, and the 6th was the final game, and he lost it. And you can see the disappointment when he's just walking out of the venue, and the way he's offering his congratulations, or rather almost turning down the handshake from the person who was just copying the moves what the machine was asking him to do. He was one of the key engineers of the Deep Blue. Well, what are the things human brain is capable of? I'm not going to list it, you know very well, but what is important for us to understand is machine learning is all about algorithms, data, and human interface. But And of course, important thing is training and retraining. Training is so important, and we'll talk about it as we go along. In terms of the characteristics of AI, the ones in the blue are the main ones: learning, perception, reasoning, and creativity. The self-correction and automation, we are all capable of doing that, but now AI machines can do definitely the first five and the sixth one as well. But is that creativity original? There is a little bit of controversy around it. Whether the creativity shown by our chat GPT and so on, is it really a original creativity? That is debatable. These are all some of the terminologies. I think if we have to work with AI, you probably need to have some basic understanding of these terminologies. And I'm not an expert on any of these terminologies. In fact, I know very little of them, but these are the terminologies we need to know if we have to work with AI. The three broad categories we need to know is ANI, AGI, ASI. The ANI is for a specific single task or a very narrow set of tasks performing very close to the level of the human brain. AGI and ASI are theoretically possible concepts not yet realized. AGI is on par with humans, and ASI a scary prospect of trumping the humans. So this is a very useful Venn diagram to understand the layers of AI. The very basic, the outer circle is a simple AI, and then is a machine learning, which can learn algorithms and apply on a new set of data without being explicitly programmed. And this is, in fact, the main things which we talk about in this presentation, the concept of deep learning. Yeah, sorry about that. The three main types in which the machine learning learns the stuff: it's supervised learning, unsupervised learning, and reinforcement learning. Supervised learning is just like what Professor Captain used to teach us, tell us what an mid-diastolic murmur is, and then we all, oh yes, this is a mid-diastolic murmur, this is early ejection systolic murmur, and so on. That's supervised learning, just like a classroom setup. He labels it as an MDM, and we take it as an MDM, and then we go on to perform in the real world. Then, for it's an algorithm learns, and then from a labeled data is labeled for the system, and the data is inputted, and the corresponding output is taught, and the algorithm is trained to identify the relationship and apply it for the future, and then it can subsequently predict the output, or it can classify the new data into categories. This is supervised learning, just like any other classroom. What is unsupervised learning? This is like letting loose the third-year medical student in the first month of the clinical posting, giving a patient, go and learn yourself, right? For no data is labeled. They are all given unlabeled data and unstructured data, no predefined categories. Nobody's telling what that patient has got, and we have to work out. And we know the corridors, what we speak. Oh, no, this is aortic stenosis, this is the mitral stenosis, and all sorts of discussions happen in the corridor. And then we get to know what's, no, this is actually a normal art. Yeah, therefore that's, anyway, that sort of things. This is basically letting loose. And the engineers just provide the playground for these machines to learn by themselves. But the machines have to find the structures and clusters. Okay, that's what a combination. Then they actually work out subsequently. They themselves learn. For it all depends upon the playground engineers. Success depends on how good the playground is, how good the data is, how good the algorithm is. For just like I got reminded of Professor V. Gopalan sir used to say, what matters is not the earpiece, but the matter between the earpieces. For it's not about the computing power, it's just about the playground the engineers create for this unsupervised learning. For what is reinforcement learning is very, very important for for a medical field. It's a trial and error approach because for example, if you're a diabetologist, you want the machines to adjust the dose of insulin. Therefore, you can't just have a static model. You want a dynamic model. For it needs to learn by trial and error approach. And its systems are given rewards and penalties. And by that way, the system learns. Oh, I got it right. Therefore, then it learns. It got it wrong, therefore it goes back. And this is a classical reinforcement learning, just like what we learn in our day-to-day life. What is this? The greatest thing which has happened to AI is the deep learning, training a model to learn like human beings. For in this, it's got an input and output. But as we know, in our brains, we have got multiple layers of thinking. We got phenomenal amount of neurons, phenomenal amount of functional neurons, interneurons, all sorts of things. The AI engineers exactly replicated that. For they created neural networks with multiple layers. You can see that in the next picture. Yeah, you can see the multiple layers. Each layer is builds on another layer. It's one layer operates practically individually and like a mini computer, and then it processes the information to the next layer. For example, you can look at a lesion and just looks at whether it's a vertical or horizontal. Then it might go and look at it whether it's a oval or a round, and so on. And then when it comes to the output, it then finally says this is malignant melanoma. But this is a very simplified representation. There are so many layers in the deep learning. And this revolutionized the artificial intelligence. But it's similar to neuron signaling from one layer to other layer. Each node is an artificial neuron, and each node acts as a processing unit. It receives input, performs calculation, passes to the next layer. It requires a large amount of data. Each layer learns something new, and it's excellent for many things which we need in day-to-day life. Image recognition, speech recognition, and processing of language. It's extensively used in medical image analysis and radiology. For what are all the general principles of deep learning? That's very, very important. We have a great role to play as doctors to identify what should be the perfect clinical question. If we get it wrong, deep learning will get it wrong. It has to have a solid training data set, a good testing data set, for which a large data sets are required. Deep learning will fail if the data sets are not very large. They calculate at least 1,000 samples are required per output, but we are talking about millions to exceed human performance. But more importantly, we need very, very, very powerful computational infrastructure. This is the problem. The concept of AI actually preceded the power of the computers. But that's why AI lagged a little bit. And most importantly, we need to ensure it actually performs well in the real world. Test trained on one population in Colchester may not apply to the population in Tanjavur. As I already mentioned about this static versus dynamic conundrum, so we need a dynamic programs. For example, chemotherapy scheduling. We need to know what dose need to give. Okay, patient hasn't really responded. Can we increase the dose or can we reduce the dose depending on toxicity? Insulin dosing, ICU management, deteriorating patient. Or do we need to increase inotropes? This all can be done by AI. How was it possible? They combined the reinforcement learning, the trial and error approach with this multiple layers, deep machine learning, and it formed deep reinforcement learning. And this is revolutionizing hospital care. But how does the machines do this image analysis? That is by a thing called computer vision. It's just like a camera. It takes digital videos and sequence of image. It can see a content. It can recognize the content. It can use deep learning techniques, pattern recognition like our human brain, process the image, and produce a fantastic output. But it mainly uses DL, as I mentioned earlier. What are all the various applications? As you would imagine, in radiology, surgery, dermatology, histology, early detection and severity of delirium because it's a labor-intensive thing. Pain, agitation, and level of sedation can be observed by the CV. Patient deterioration, fall detection, and any aspects of the patient pathway, if it involves a visual image, can be done by computer vision. For just moving on to a specific area, I'm not going to cover all the applications of AI in medicine. It's impossible. Therefore, I'm just going to pick up one area which is relevant to my field in which I work, and then a couple of just a mention about cardiology and other things. How AI transforms stroke care. We were taught in our physiology that brain damage at the point of ischemia is instantaneous, irreversible, and predictable. But it's not 100% true. Yes, it may be true in certain a proportion of patients, but it is certainly not applicable to a vast majority of the patients. For we need to dig deep, and researchers have come up with these four concepts of analyzing parenchyma, which is the brain, pipes, the blood vessels, perfusion, what's blood supply each part of the brain is getting, and how much brain we can save in the context of an occlusion, how much brain is dead and how much brain can be salvaged. That's penumbra. Yeah, therefore, the problems for us is that we don't have neuroradiologists 24/7 in NHS. Nobody wants to work outside 9 to 5, and it's a big problem. Unlike India, therefore, it's a huge problem in the Western world. As they become consultants, they do not want to do out of hours on calls and so on, and there is generally a shortage of any specialty for that matter, and it's very difficult for a non-neuroradiologist to work out the size of the penumbra. And also, we need to transfer the images very quickly if the patient is being transferred to a nearby hospital for a thrombectomy. For it's a bit of a problem, but that was the issue we all were facing in NHS. Therefore, the AI systems were introduced to exactly tackle this. For the E aspects is from Brainomics, one of the AI companies product. This is what we use in our hospital. As I already mentioned, I have no commercial interest with this particular company other than using it. And its early aspects is early ischemic score, or is the brain is actually showing signs of early ischemia? Is there an occlusion in the middle cerebral artery, which is CTA? And CTP is the perfusion scan, which will tell us the size of the penumbra, which is a tissue which can be saved. And this information is available within a minute at the most on our mobile phones. And then it's also available in hospital computers and tablets on all formats. It's very easily available. You can see these formats in the picture over there. Well, let's take an example. For example, many patients with this condition have been missed by even radiologists. Um, uh, you can see on the left-hand side of the brain, on the right-hand side of your picture, you can see a bright white line and a bright dot. And that's the dense middle cerebral artery where there is a thrombus. It's not a contrast, the plain CT, because in a plain CT, when there's a thrombus, it appears white. And this can be easily be missed. Now we have got a fantastic treatment option of thrombectomy, where even anybody can identify this, but it's not easy for a non-specialist, somebody like an emergency department doctor, to identify this. But AI can instantly pick this up within 30 seconds and can point out, and then a referral can be made for thrombectomy. That's the advantage of AI. It doesn't get tired. But even we have had cases. There are multiple case reports in the literature where a radiologist have missed this, because at the end of the day, when after reporting 100 scans, then you can easily miss this. It's human to miss this sort of scans. And then this is early ischemic changes, as you can see on the right hand side, and the AI picks it up and puts a nice red sort of red blobs wherever it can pick up the early ischemic changes. And again, it points out to the blockage of the middle cerebral artery. And this is the most useful aspect of AI. This is on the left hand side is the core damaged tissue, dead tissue. On the green is the dying tissue. Therefore, if you subtract If you subtract the pink from the green, that gives you the penumbra. Then you work out the penumbra and then decide whether to give thrombolysis or even refer for thrombectomy. This is really fabulous, and this is done in less than 30 seconds, while even a neuroradiologist might take 5 minutes or so to calculate this. As I mentioned to you, we launched this AI in our hospital. And of course, this was picked up by local press, and obviously they're going to exaggerate. As you can see, life-saving. It's not really a life-saving AI technology, but that is typical press for you. But this is really even a slight holy grail for AI at this stage, because this, I don't know whether anyone can actually spot an abnormality in this scan. I just give a few seconds. Anyone can type on. No, I can't see anyone has typed it, but anyway, on the middle is, you can see a bright dot which is not there in the left and in the right. For we are talking about a basilar thrombus, a thrombus sitting. It's a plain CT scan, nothing great, simple CT scan done. There are numerous scans done in A&E for different conditions, and it can, even a tired radiologist can miss it, this sign, and it has been missed in our hospital, in many hospitals, and there are many case reports. This patient will go on to probably develop locked-in syndrome and will be paralyzed for the rest of the life if it is missed. Therefore, this sort of things are great for AI. AI is not going to be tired, and if it is skilled enough to pick it up, it will pick it up. At the moment, it's a bit of a challenge for AI as well, because why it can pick up a middle cerebral artery occlusion, it cannot pick up this one. It can pick up, but most programs at the moment is not licensed to pick this up, because probably they haven't got enough data sets for this. This is relatively much less common when compared to a middle cerebral artery occlusion. Therefore, they've probably got millions of data for middle cerebral artery occlusions, may not have that much data for basilar occlusion. That's the only reason I can think of why it is not licensed by every single AI system. Well, this is a typical way the machine learning, deep learning, particularly learns the model. Lots of images of different modalities are fed into it, and it processes it. It enhances the image. It applies its algorithm, and then it tests itself against an external data set, and then it released into the clinical practice. AI has been applied in many areas of stroke, diagnosis, prediction, risk of stroke, etiology, complication prediction, comorbidity, and aiding the rehabilitation. And I'm going to focus on the last bit, a brain-computer interface. The brain-computer interface is actually, there's a very well-established lab, one of the leading labs in UK, in Colchester, in the University of Essex. We collaborate with them as well on the BCI. BCI is nothing but establishing a direct communication pathway between the brain and an external device like a computer or a robotic limb. Because the problem is in a stroke or any neurological condition is these fibers between the brain and the effector organs like a muscle. That's the problem. Therefore, if you bypass the neuromuscular pathways and make the brain to connect to the muscular systems, then the person knows what to do, but the signals are not coming. Then somewhat we connect to the muscles and we can make the muscles do things. And that's exactly BCI is. For BCI, translate the brain activity into commands, and that can control external devices. We can use a functional electrical stimulation. We can use an exoskeleton, which is basically a robot, and the patient can walk. Yeah. For patient knows I have to walk or I have to move my limb, for they can be attached to an exoskeleton and they can move. For this is the beauty of BCI. I think someone is actually put the mic on. Yeah. And thank you very much. Yeah. For the next one, which is effective in dermatology, is this one, which is currently available, I think, around 30 hospitals, NHS. It can redirect the benign skin cases to a non-urgent pathway. It can pick up the cancer, 97% of cancers, with a negative predictive value for melanoma of 99.8%, as good as a dermatologist. But they say that this currently we have to be very careful for a brown skin and for black skin because it can be a problem and because there probably may not be that many cases. Therefore, we have to be careful with that. Therefore, I think that's nice has made a very explicit recommendation about people, of different races. Yeah. And artificial intelligence, there's also artificial intelligence technology has also been extended to fracture detection of fractures, and that is available in our A&E in many hospitals in UK. For the sensitivity is around 70%. For they have recommended that it has to be used along with a doctor, but by a junior doctor or a trainee doctor, by combining the AI, they were able to pick up more fractures. In other words, it's an assisted AI performing better than a trainee doctor. Clearly, it's not at the moment. I don't think it's good as a radiologist. Moving on in cardiology, I'm not going to list everything. You can see that ECG, wearables, echocardiogram, CT, coronary angiogram, so many areas. The AI is being applied and being tested and being used. In oncology, even greater use of AI in oncology, I would say, in diagnosis, screening and early detection, tumor staging and grading, and new oncological treatments. AI is great in for coming up with a new drug. I think in my opinion, I think that's where our AI, we need to spend a lot of time and energy in Indian forests, Himalayas and Western Ghats. I remember reading an article that our Western Ghats and Himalayas probably have got all the medicines the world needs. But we need to identify where the molecules are in this wide variety of plants and trees found in the world, especially in India. And I don't know who, can anyone tell who this person is? He won something great this year. Is Demis Hassabis. This is a Nobel laureate in chemistry, but his CV is phenomenal. For he actually founded the Deep Mind, and his famous quote, in fact, from the Deep Mind, his mission is to solve intelligence, and then use intelligence to solve everything else. So he's basically saying at the moment the brain is not intelligent enough in a way. I would say you could interpret it that way. He's a child prodigy. He's from in North London. He was a child prodigy, and he earned money as a video game programmer when he was in probably 78 years old. He's a chess expert, and he did PhD in cognitive neuroscience. And you can see the combination what it is going to do. And then he went on to do computer science in Cambridge, and he won a Nobel Prize for chemistry. I will come on to that in a minute. But what did he say? How would we solve the problems such as cancer, Alzheimer's disease, and so on? And he said that humans are very selfish. They are not going to do that. They are not going to work together. Therefore, we need machines to do that. That's what he basically said. Well, what happened? Another seismic change happened around, I think 2017, 2016, 2017, 2018, around that time. Something called Alpha Zero was introduced, so-called Creative Alpha Zero. So what it did is, unlike other machines, it was just given rules of chess, our queen moves, our rook moves, and so on, and it learned chess itself from scratch, solely from the game rules, and it surpassed the human designed engines. It trashed all the chess engines, and of course it trashed the human beings as well. And it completely bypassed the reliance on human expertise, and it also learned other games, and this was considered a paradigm shift in the AI development because this is going to be used for something else as well. That's what Demis Hassabis thought through. For people thought, is this the beginning of end of humanity? No, because he went on to demonstrate, the deep mind went on to demonstrate, but deep mind is now with Google has bought deep mind. For they basically came up with a fantastic solution for protein folding. You know how the proteins fold, and people took years to identify how a particular protein will form into a structure. An alpha fold will give it in a few minutes. Well, you put up all the amino acids, it tell you the structure of the amino acid in few minutes. It was basically built on the Alpha Zero platform, which was designed for chess. And then now we've got a genie which can dream up new proteins. Why it's important? Because if we want to find a new cure for a thing, we need to come up with new proteins. Then we can design molecules. We can design antidotes for those molecules. And the genie can dream up entirely new proteins from any amino acids. Well, next, we move on to natural language processing. It is the computers can understand, interpret, and generate the language. That is basically your ChatGPT and so on. It's part of ChatGPT. For now, we are really going to go on to generating content from AI. So far, AI is talking about analyzing the existing content, but now AI can generate content. It can generate text, images, and so on. Basically, it uses a DL, and it stimulates the learning and decision making of human brain. This is called as a generative AI, and this is revolutionizing many fields, including medicine. But it needs a vast amounts of data. By encoding that, it responds with the new content. And you might have heard about Gemini, Google Gemini, ChatGPT. They're all large language models. Llama, and then they can generate the text. You ask a question, it can generate a text. That is large language model, and that is a type of deep learning algorithm. Basically, it's based on deep learning algorithm and natural language processing. That is the ability to understand the language and merging with the deep learning, and it is coming up with a large language model. As this pictogram represents, you got artificial intelligence, you got machine learning, you got deep learning, and you got NLP, and you got computer vision, and that the meeting point is the generative AI, which generates new content, and that is done by the large language model. It can be used for augmenting knowledge, medical education, research, and administrative tasks. And this diagram very nicely pictures what programs are equivalent to frontal lobes, parietal lobes, temporal lobes, occipital lobes, and cerebellum and brain stem. So we started a little bit late. I'm just going a little bit fast. And what is the evidence for AI? China and USA dominate 30% roughly each. And I couldn't find any study from India. And main fields are gastroenterology and radiology. And mainly focusing on most of the studies are based on for AI or on diagnosis, as you would expect. And I've given you the reference if you want to read that paper. And then most of the studies focus on AI assisted cognition, therefore AI plus cognition rather than pure AI versus cognition. And this is the 5 levels of automation. Automation 1 is just data. Level 2 is cognition plus AI. And 3, 4, and 5 is purely autonomous. Most of the AI at the moment are either 2 and 3. 5 is scary. That is AI doing everything on its own. Level 4, it's mostly autonomous. And level 3, it will call the clinician at its own request. For if it's not sure, call the expert, right? For most of the AI platforms are 2 or 3 at this stage. There is no 4 and 5 as far as I know. For how to critically evaluate an AI paper, just like any other medical, look at the study design, what's the purpose, what is the computer model used, what system is used, at what clinical pathway AI was used, what data was used, algorithms, did they take into account the human factors? Is it clearly explainable to the people? Because they are, okay, what did you use, doctor? I used ChatGPT. Tell me how ChatGPT works. That is explainability. And are they being transparent? Probably not. Did they use multiple levels of expertise? These are the things which you can use when you're evaluating a paper. And when you're evaluating the paper, don't look at sensitivity and specificity. You just look for LR plus and LR minus. I'm not going to go into the details. This is better way of analyzing any particular test, whether it is as good or not. Sensitivity and specificity do not take into account the various factors which are very relevant. Well, these are the various applications: healthcare administration, clinical decision making, diagnostics and imaging, predictive precision medicine, drug discovery, service delivery, population, biomedical research, and medical education. It's got a great role to play in research, in every aspect of research, trial design, enrollment, and managing the data. What are the benefits? Administration, doctor-patient interaction. You have more time because AI does every job. You can spend more time with the patient, and you can give personalized care, and you can practice precision medicine, and you can patients have a lot of information available because of AI. Challenges and limitations: accuracy. It can hallucinate. Remember, you will find in chat GPT, please check the reference may not even exist, or it can come up with its own cooked up references. Chat GPT or Gemini, it applies to everything. So please be aware of hallucinations. Don't take it as gospel. Check the original references. Inconsistent outputs. It can be biased against people of different races because it hasn't got data of different every race. Performance drift: as time goes by, performance can go down. I already talked about explainability and transparency. Security of the patient's data, privacy of patients, intellectual property concerns. Who is liable? Is the machine liable, or is the doctor using the AI liable? And may not be able to deal with social and cultural aspect of the disease because machine may not know that. While doctor know, oh, this patient is from this background, I've got to be a bit careful when I'm going to tell this. But machines may not have that. It probably will, but it at the moment is struggling to do. And because of all these factors, people don't have trust, including clinicians. And this is like a pro and con. It can improve access for marginalized groups, but can also widen the inequality. People in a rural village may not have access to AI. A doctor sitting and practicing in rural areas may not have access to AI, while a doctor practicing in a advantaged area will have access. It can improve patient relationship, but it can also worsen because, oh, this doctor is relying on AI, and that can worsen the relationship. It can improve the job quality. It can increase the job burnout because AI gives so much information to the doctors. They get clouded. It can improve efficiency. It can increase the cost. AI is not without cognitive biases. Dr. Morley gave a fantastic lecture on cognitive biases. Certainly, Dr. Morley would be interested in this article. Read about it, please, if you already not read it. It is prone for different cognitive biases, and therefore don't think that it is not biased. It depends on what data is presented to it. If you ask the AI, give you the survival data, it does differently. If you say that in exactly the same data, you present it as the patients have died, it give you a different treatment option. This is a very, very good paper. And what is narrow medical AI? Just like just picking up a CT scan or a CT angiogram. It's very specific, and doctors have to deal with multiple AIs in an hospital. Therefore, what we need is a generalist medical AI, which is capable of doing diverse tasks. At the moment, it's not available. It is like a single super doctor knows everything and can deal with everything. Clearly, AI is not there. At the moment, it's essentially a narrow AI at this stage. What is the solution to this? To come up with collective medical AI. While we're waiting for the GMAI, the collective medical AI is what we should work towards. We can potentially integrate 4 systems like ECG, echo, and so on. And this collective medical AI could give some information about the patient, combining these different systems, narrow AIs. It should never be AI versus humans. And it's all about how we interact with AI. Algorithms and data are great, but it's the interface which matters. And again, I go back to the chess. We can learn from chess. And Kasparov, after being beaten by Deep Blue, he said, if we cannot beat the machine, let's work with the machine. And that's what we as doctors, we should do. I don't think we can fight against AI because there is too much money there, and it's actually has got lots of benefits as well. So there's no point in fighting. We should use it. What was the transition model chess adopted? Probably people may not know. It's something called advanced chess. Vishy Anand used to be an expert on that. And basically, they played with the machine against an opponent. They can use the machine, and then whoever beats. But actually, it's no longer relevant because the machines trump any top chess player very comfortably. But how do we work with AI? We can work with the developers. We can evaluate them. We can provide data for local population. This is, I think, very, very, very important for Indian population, and we should monitor and evaluate. Local training of the staff that will help them to develop trust. Data security and privacy of our patients very important, and we should inform the developers about the bias and lack of awareness. We should encourage the developers to be transparent and make it explainable. Some of our youngsters should become digital fellows. They should act as a bridge between medicine and AI, and they should have a direct channel with the developers. But the governments have got a huge role to play, for they should legislate for everything. And in another 20 years, I'm not Alan Turing to speculate what's going to happen. Maybe governments have to step in and stop AI in certain areas, the way it is progressing. And you say, otherwise people will be without jobs, for governments have to do something about it. For this is the impact. Look at the dark blue. That means people will be without jobs in this area in this timeline. In speech recognition, at a much early, radiology early, robotics very, very late, AI will struggle, predictive analytics around 2035. This is the impact on the current workforce model. So my last two slides, and as promised earlier, therefore this picture is from the World Chess Championship, and US was desperate for a World Chess Champion after Bobby Fischer. And the man on the right is Caruana, and the man on the left is probably one of the greatest of all time, Magnus Carlsen. And the man in the middle is one of the British Grandmasters, which is a commentator. And this happened in the game between Carlsen and Caruana. And Caruana was playing black and Carlsen was white. And at that stage, before white made that move with arrow, and it was equal. The machine said is equal, and Carlsen played that bishop move, and the machine straight away said Caruana is winning. If Caruana had won that match, maybe he would have gone on to win the World Chess Champions. And including the commentators, nobody had any idea about why black is winning because of that white move, which was looking innocuous at that stage, because clearly, and then what happened after the match was drawn, because Caruana thought it was a clear draw and he offered a draw, and Carlsen also thought it's a draw. They accepted a draw, and then they came for this press conference, and this Daniel King had to use the computer to explain to these great geniuses, Carlsen and Caruana, look at the expressions in their face, and then they explained, and he just made the computer to play out the moves, and Carlsen looked absolutely perplexed there, as you can see, and he went on to say, I'm not going to disagree with the computers. I simply just don't understand it. And that is the impact AI had on chess. But certainly whether it will have the same impact on medicine, I can't tell, because there are so many other permutations and combinations, and there are so many challenges. Whether AI will trump medical professionals, I'm not sure. It might. But what is important is, should we be excited? We should be excited, in my opinion, but we should be very cautious. We should be engaging in this whole process with the developers and using the technology and so on, but we should be very, very, very critical, particularly post-market surveillance. We should do that. I think it's very, very important that we are very critical. But though we remain excited and engaging and cautious and critical, but I strongly believe that we should embrace it. AI is just like the gloves in this chat GPT picture, and is the doctor on the left is the doctor who uses AI, and the doctor on the right is the doctor who does not use the gloves, and you probably will know what the outcome is. I think this is my current assessment of the situation. If not necessarily right now, but in a matter of time, this will be a fair representation of what's going to happen. Thank you very much. I'm happy to take any questions.
Thank you, sir. That was a very lucid and elaborate presentation, starting with Alan Turing, the great Alan Turing, and then you progress to but Geoffrey Hinton, the other Nobel laureate, there was no mention of him. Why is that?
I think that is a very interesting question, but obviously I keep the talk interesting, I suppose. AlphaFold, and there's many people I could even talk about AI, and of course it's not only Demis Hassabis, but also the other person who worked with him. I can't remember on the part of the chemistry for the protein fold, AlphaFold. There are many. McCarthy also is considered to be the father of artificial intelligence. There are many people. Obviously, I have to maintain a particular angle to my presentation. And I think Demis Hassabis perfectly fitted that label. And I think again it's impossible to cover so many people who have contributed to this fantastic field. Yeah. Only I can only
Hinton,
apologize. I can only
yes,
apologize.
yes, sir. Hinton has become some sort of a messiah against AI being taking over the world and his doomsday predictions. I
Yeah.
think. What do you think of the downsides of artificial intelligence in general, apart
Yeah,
from
I
the
think
ones
there's going to be
listed?
a, yeah, absolutely. There is going to be a massive impact on jobs, certainly. And other, I think our cognition will get eroded, I think, because we will become increasingly reliant on AI. And it will have a negative impact, no doubt about it. But there are lots of positives. But that's where the governments come in. How are they going to legislate? It's challenging, and it's driven by a huge commercial push. Um, I think it's an unknown area. But remember, in chess, if you just again go back to chess people, AI as not, clearly machines can trump AI, but sorry, I mean human brains. I mean, but still, chess has become more popular since the AI. People watch YouTube live, millions and millions watch and compare their thought process with what AI is suggesting. Yeah, I think that's what we all should probably use it. Is should learn to use it. How we use it for just like you can box without the gloves. Certainly yes. Yeah. But you can't do anything about it. It's like Nixon, American president, said we have to learn. He said there's no point in fighting against an atomic bomb. We should learn to live with the bomb. I think that's what he said. I think that's true, isn't it? Yeah.
Members, if there are any further questions or comments, you can unmute yourself and go ahead, please.
Dr. Bose here. It was a very nice talk, very elaborate, and I think we need an AI to interpret your whole talk as such. A very elaborate one, I would say. For my intelligence, I think it is too far fetched. The other thing, what I wanted to say is, so if an AI is going to give a decision and your tumor board or your board doesn't agree to that, how do you solve it out? So that's going to be a big problem. For example, somebody takes a decision on chemotherapy and they say it has to be given, but your AI says that it should not be given. So who is to, bell the cat?
Yeah, at the moment, it's most programs are level 2 or level 3. At the moment, the clinician carries the can. Uh, I think again you are correct, because if the AI says don't give the treatment, and if the MDT says give the treatment, and the patient goes on to have complications, and then a patient in at least in UK will have the right to ask what the AI say or mentioned in its report. And
Correct.
again, the medical legal implication would have to be preempted
Yes.
and legislated. Yeah, exactly. Therefore, you
Mm.
can't. Yes, exactly. That's a very good question. But because we focus on missing AI, missing it, AI missing a large vessel occlusion can be a problem. Patient will be denied thrombectomy, and clinician carries the can for that. Yeah.
Now,
Uh,
is it that the court would agree to the AI, or would you think the court would say it's too early to believe in AI?
No, the courts will, that needs to be specified before you implemented it, because that's very important of your standard operating procedure. But there's
Okay.
no point. That's exactly the thing. There are lots of things need to be planned in advance, that in that situation we will not accept the AI, and is the MDT's decision is final. For
Okay.
if you launch something and then later on a problem comes, it's very difficult. And the
Mm.
AI cannot say that because it's covered by your policy, isn't it? Then I mean, they might call the expertise into question, but
Okay.
again, It
I
depends
think
on
it
the
would not
external
be a
expert.
negligence. It wouldn't be a negligence, right?
It wouldn't be negligence, definitely not.
For example, a fracture missed out or a
Yeah,
radiological diagnosis missed out, right?
it
It
would
won't
not
be a
be considered
negligence. Yeah.
negligent. No, no
Okay.
way.
Right. That's good. So
Can I say something? Boss, this is for boss. Boss, this is Ravindran.
yeah, Ravindran, yeah. Tell me.
Yeah. See, AI can be, as far as I know, no, okay, the AI can be used as an assistant, not as a master.
Okay.
Now, let us say, I mean, no, we get our knowledge so far, no, before computers, we got our knowledge from our books. And
Correct.
at times, no, you ignore books, whatever book says, no, you ignore, because it might be, no, in your situation, no, that might not work. And you use your own discretion and then go ahead with the treatment. So
Correct.
similar principles should apply for no AI also. AI might say something. See,
Yeah,
if
I agree.
AI, if you are using AI, well, I should know what AI says is correct or not. I should be able to judge. In
Correct.
case if I am not able to judge, then I should verify. If AI says something which I didn't know or I missed, let us say it has got some fracture, but then I am not able to see, then you have to verify. I mean, you have to use some methods to verify, and then only you have to take a decision. Of course, if you go to court and then no court in court you say that no, the book says so, that is why you followed something, the court might accept. But if it is AI, the court might not accept, at least present. Maybe later, after 25 years or 50 years, the court might accept. But whatever it is, the AI can only assist you. AI cannot be your master. This
Okay.
is what I think. Yeah.
Yeah. There's one important caveat in this is one of the things the AI developers are worried about is, for example, Dr. Bose, is that, for example, you use AI, but without telling anyone, and you take a decision and you don't reveal it to anyone, right?
Right.
And then this is a big problem for AI developers because they want that information. They don't want clinicians to secretly use AI
Okay.
and take decisions because they need to learn. They need your expertise. They need your what happened to the patient. This is a big problem for them. Yeah, but secretly using the AI.
Okay. So secret use of AI, how are we going to prevent it? For example,
No,
now
you can't. You
everything is
can't.
available.
They are
Yeah.
only making a plea. Please don't do that.
Please,
But we
that's all.
will.
Okay.
But
Right.
we as doctors, we will. Because we
Right.
know that in a particular situation, it can predict better. And then we might use it and we don't reveal it to anyone. Yes, it's a problem. Yes.
Okay.
No solution to that.
Right. Nice.
I have a question. This is Syed. I'm calling from St. Louis. Wonderful talk, Dr. Shiva. I just had two questions. Number one is with AI, you have acute intervention. Now, does
Yeah.
that relate to a better outcome at the back end? Like me being a rehab physician, we hope that's what it's going to do. But the selection of patients of what you're going to do to them, would solely be based on the AI. When you make the decision fast, but is the outcome going to be better? That's number one. And the second question is with the advent of AI, already there's a big disparity between healthcare, between the have and the have nots. So you have countries that have AI is going to go pretty fast, and the people who do not have it are going to be lagging behind. So what are your thoughts on that?
Yeah. Thank you very much, sir. I know you quite well. Very excellent sportsman. And yeah, I think the first question is that I think in terms of rehabilitation, I think the predictive model based on the data, even for stroke rehab, I think AI is really good. Because it looks at the whole pathway. I think, in that particular area, I think AI will perform quite well. But of course, as we all know, in a single patient, prediction can go wrong. But I think it's probably going to do a better job than us. The second question is a huge problem. Yes, definitely. Yes, even in our patch, because some hospitals were using AI during COVID time, and clearly, and some hospitals did not have time to set it up, and all sorts of problems. And certainly, haves and have-nots is a big problem. I don't think we have got a solution to that. Just like with any other expensive treatment. Yeah, if you have it, it's great. If you don't have it, you have a disadvantage. Yeah. Thank you.
Thank you.
Very nice talk, Dr. Siva.
Thank you.
My question is, based on AI-based algorithms, can you envisage early diagnosis of Alzheimer or in Parkinson versus atypical movement disorders, whether we can make a difference?
Yeah, it's a big area. Yes, definitely, because certainly it's a very ripe area. It's already there, Molly said, because it's Alzheimer's and Parkinson's and on and off dyskinesias, because you can just use computer vision, and then you can adjust the doses with using the computer vision I talked about. Yeah, you can observe the whole patient, whole 24-hour period, and you can adjust the doses. Alzheimer's disease, clearly, it's got so much millions of scans, and it can predict who is going to develop dementia or not. But it is good thing to know or not, I'm not sure. Will people want to know, have a brain scan and want to know, whether they're going to develop dementia in 5 years' time? That's a big problem. That's the ethical aspect of it. Yes, certainly in that area, yes, AI will trump any radiologist in predicting whether someone is going to develop dementia or not. Yes, certainly yes.
Because that's the big thing which is coming up, that unintentional detection of disease. Like there
Yes.
was a very interesting paper that based on a chest X-ray, you are going to tell whether the patient is going to develop type 2 diabetes in future. There are so many other things where incidental detection of totally unrelated pathology based on an organ which you are imaging for some other purpose. So that's another thing. Whether it's going to be a boon or a bane, we have to debate again.
Yeah. Who is going to give insurance? Who is going to give life insurance? That's a big problem. Yeah.
Like today, there was a nice paper on in vitro fertilization. AI helped because it picked up a sperm of a good quality, which other techniques could not.
Yeah. Yeah. It's every day. In this 1 hour, AI would have invented millions of things. It just keeps tireless, isn't it? Tireless. It just keeps learning all this deep learning, multiple layers. It just keeps producing new stuff all the time. But one thing is that the performance drift people need to be understand. It's a very complex concept. Just because a program was fantastic in 2025 doesn't mean it will perform the same in 2028. It's because of this the concept of data concept, where the data changes, the input of the patients are changing because it learned on a group of patients, but the patient's characteristics have changed in 2028, for example, then it will not perform well. Yeah, but people, for example, so many features that you can have a body mass index or something like that. A body mass index in, say, in 3 years has gone up. Average BMI has gone up in, say, in 2028. For it is not going to perform to the same level as it performed in 2025. For this is very important. This is called as a performance drift. Just like we get old and we don't perform as well as it used to be, the same thing. Yeah.
Maybe we need
but
to.
Of course, we have a different explanation for this. But the AI's problem is different. Yeah.
Maybe we have to keep on recalibrating them or the new.
But the problem is users are not providing the data back to the developers. That's the big problem. That's where the commercial problem, because lots of users use this AI and they are not providing the data, what happened to the patient, unless it's mandated. UK, it's mandated for the fracture. They have to provide data for 3 years of all the x-rays the AI is going to interpret. But that diagnosis, the final diagnosis, is not going back to the AI developers all the time. For this is a big problem.
I had just sorry for the questioning. There are two. When you said the providers are not giving the feedback, I'll give you an example of the time difference it takes to make a change in an AI model. Is probably pretty long because, for example, we are using, for simple purpose, I'll say we're using what's called as a nuance DAX system here as a pilot model, and I think some other centers are using it for dictation purpose. You take the app in the room, you talk to the patient, it converts it into a clinic note. As you step out of the room, you get a clinic note on file. So now what happens is there are so many mistakes in it, we keep correcting it. And I talked to these people in Microsoft because Nuance was taken by Microsoft. What they say is you can make your suggestion, but the time you make a change is going to take may take years. because they
Yes.
need that amount of data to be collected to make the change, they say. They won't do it for one person or two persons. And that's the sad part of it.
Yeah, I agree. I think that's why the multi-center involvement is very important. Therefore, you have 5 patients, I have 10 patients or something like that. And if everyone provides that data, they need data. This deep learning models needs vast amounts of data. Yeah.
And another thing on the sideline, on a lighter vein, I just wanted to tell, probably you let me know. ஏ இருந்தாலும் பிஏ இருந்தாலும் தலையெழுத்த மாற்ற முடியுமா?
Absolutely. Absolutely. I totally agree with that. Yeah, totally agree with that. Yes.
Because imagine if AI, all these guys who are reading horoscopes will be எங்கேயோ டாப்ல போயிருவாங்க இப்பெல்லாம்.
Yeah.
No,
Thank you, sir.
regarding clinic notes, again, we discussed how AI itself truncates the clinic notes, eliminates social related information, the
Yes.
chat which the doctor had with the patient, all that has been pruned by AI, and it makes it so sanitized version, and you lose the human aspect of interaction finally when you read the notes. So that was a nice paper in NEJM which I discussed also.
Yeah,
So
it's
that
because
again,
of ambient recording. Yeah, it's because ambient recording. It is very, very good ambient recording. But I agree with that particular point. Yeah, definitely yes.
Even for the AI summaries that I get for the Zoom meeting, sometimes you find that they kind of missed on all the nuanced points, and you have to go back and kind of correct it. So I think
It's
it's
kind
got
of a
scope.
sterile note.
Yeah.
Today I got a beautiful description about Kuam River. It had hallucinated the Meta AI from WhatsApp because I think Dr. Murlidhar had asked some Australian who worked about pollution in Kuam River. I just typed Australian tourist and Kuam River. He said Australian tourists are interested in adventure sports and Kuam River is excellent. Total hallucination.
Yeah. Sir, there is this recent orchestrator, the diagnostic orchestrator by Microsoft, which kind of instructs across all platforms, all the available AI tools. And then it comes out with, it kind of trumps all the complex cases in NEJM with 85.5% accuracy. I mean, how does this orchestrator thing work? I mean, I couldn't understand, how it really works. Any idea about that?
Yeah, it's basically uses large LLM models. That's all. That's what it does. But in fact, there's a lovely critique of that article as well, because one of the things is that, as you would expect, when you go to a grand round or a case conference or something like that, it's actually much more easy to diagnose the final diagnosis than seeing a patient in real life, because someone is really presenting it in a grand round. That means it must be an exotic condition. Then you start thinking along those lines. I think that's what they think. It's probably the case records of the NEGM is basically know that there are some rare cases, not your common case. And of course, the LLM models are going to have got phenomenal amount of knowledge under their belt, and they're going to pick it up easily. Yeah, but in a real world, you come across an ordinary respiratory tract infection to vagus granulomatosis. Someone presents it with the upper respiratory tract symptoms, isn't it? That's the thing, because in that situation where case records of massive human brain probably won't compete, because you haven't got that level of expertise at the at your tips, because there are very rare cases, isn't it? All the cases records of are very rare, and we all have read those cases, but they are rare cases. It's not easy for a physician to get everything right, because I may have interest in Still's disease, and you may have interest in Alzheimer's, for example, different rare conditions, vagus granulomatosis and so on. But LLM, it basically treats vagus granulomatosis and Still's disease in exactly the same manner. Yeah, isn't it? Yeah, no biases there. Yeah. Therefore, that is not surprising. That particular paper is not surprising at all. I don't think it is got much relevance in day-to-day practice, but when you are stuck, you know that you can go to chat GPT and put all the symptoms. It's probably going to get the diagnosis faster than you. Yeah.
One more issue is the environmental impact. AI seems to be an energy guzzler, and enormous amount of energy is being utilized on the planet, especially the resources are they're not infinite, they're finite. So is this going to be a problem in the future? how much
Yeah.
impact it's going to have on climate change.
Oh, definitely. I mean, that is very difficult to work out. But certainly, apparently this massive computers and systems and models require large amounts of energy. But it apparently it can has offered a lot of solutions for climate change as well, which human beings hadn't thought of. But I don't know where the trade-off between the two. Honestly, I don't know the answer for that, Venkatesh. But it's an area which is debated even in lots in BBC almost every day in UK. Some article around this area comes up.
I mean, that question that you raised, Dr. Nataraj, can be even extrapolated to what we do. I mean, I think sometimes, like a devil's advocate, maybe please tell me I'm thinking wrong. I hope I'm thinking wrong. Is what we do in medicine a lot of times is we prolong life. Now, is prolonging life equivalent to prolonging the quality of life? So now, when people get older and older, you are using resources and you're not being productive. So does that mean the resources from the old or from the young are given to the old, or they're shared? By Earth or whatever we call it. Now, advent of any new, interventions, maybe, even starting from replacements to hearing aids to cataracts. One is for quality of life, but also it is a burden on Earth when people live longer, in my opinion. And that's why we got to find some other place. And I think that's why Mr. Musk is busy shifting off to see if we'll have life on Mars. Yeah.
Yeah.
Now, am I wrong in thinking that way? May please, Dr. Muralidharan, and who people have so much vast experience. Like, and I always make an example when we get older, when we can't walk. Sometimes we say nature gives us that thing. Says, "Hey, I'll give you arthritis so that you don't fall. I'll give you a little hearing deficit so that you don't hear anything that's too bad around you. I'll give you a little eye deficit so that you don't see what is too bad around you." But what do? We get an intraocular lens, get a hearing aid, get a new replacement, and off you're out to the races to get a Viagra. So that's life.
In
I
fact,
think
one of
there's a
the
one question from Dr. Subramaniam is about who bears the liability, doctors or the AI developer. Again, it needs to be clearly mentioned in the standard operating procedure before you implement a system. As far as I know, it's the doctors, because there is most of the AI products are assisted products, assisted, by the clinician, or they always have a caveat saying that clinical correlation is required at the moment, um, uh, except that skin one. But again, NHS probably carries the liability for that skin system. But I'm not a dermatologist; I don't know how it works. But that has got a system where it can independently operate, but it's only for a benign thing. Yeah, it's a very interesting question about who carries the thing. But I can tell you one night a very interesting incident which happened in one of my recent ward rounds. I was doing a ward round. I saw a patient who was comatose, and my registrar was with me. And then I asked asked them, my juniors, what are the types of breathing in a comatose patient? And then they mentioned a couple of things, but they missed out central neurogenic hyperventilation. That's what patient had. And I said, this is central neurogenic hyperventilation, and that registrar hadn't heard about it. And then what I was doing something else, and he quickly checked his phone and asked the AI, and he probably asked, I can't remember exactly what he typed in, but what types of breathing, and he didn't mention central neurogenic hyperventilation. And then he told me, Dr. Sivakumar, the central neurogenic ventilation is missing. And I said, that's wrong. It has to be there. And then he typed in the computer, in the AI system, saying, yeah, my consultant is saying you are rubbish. And then you missed out central neurogenic hyperventilation. And if it's a human being, it will react, I'm not rubbish, or something like that, get angry or something like that. It very casually replied, yes, your consultant is right. And then it gives another 100 lines about central neurogenic hyperventilation. But this is the way AI reacts, because, but in terms of yeah, carrying the liability, developers or programmers or ChatGPT, they don't carry the liability, because at this stage, it is all the clinicians who carry the liability. Yeah, I'm just giving you a scenario. I just want to tell you how unreactive it is. Now as you'd expect from a machine. Yeah.
In the US, I mean, there's a growing problem is with insurance companies and AI. Like, they use AI to deny healthcare.
Yeah.
So it's going on at courts of, why should health insurance companies use AI to deny an individual's healthcare? Does it personalize healthcare to that extent? Whereas it's a big platform, a decision they make that so and so is denied this particular care because through the AI.
Yeah. It is a big problem, Syed sir, because even driving as well, isn't it? Because all the EV cars are going to learn our driving practices and skills, I suppose, and then we might have to pay different premiums depending on our driving expertise. Yeah, it's a big problem. Yes, the more they know about us, um, more they are likely to come after us. It's a commercial world. Yes, the whole AI is commercial world. Yeah.
The whole AI is a commercial world, so is medicine. I think probably everybody read the one on New England Journal of Medicine. I think it's about corporatization of health. Yeah.
Yes.
Wonderful talk, Sukumar. You really stirred up a lot of thought process. Thank you.
Thank you, sir. Thank you very much. Yeah. You probably remember me, I suppose.
Dr. Bose here.
Yeah.
There was an interesting query, philosophical query from Dr. Syed as to how long should you treat a patient, right? So we are really, as oncologists, perplexed with such situations. So it's basically here the relatives and the attenders decide how long a patient should survive. It's basically the patients are not given a great option. Even though we discuss with the patients at that moment as to what sort of a treatment he would like to have, the patients are not in a position to decide about what they really want. This is because there is a lot of lack of transparency in the amount of health care that we deliver for our patients. So invariably, the attenders take the role of deciding how long a patient should be treated and what sort of a care he should get. And this leads to a lot of problem in unnecessary ICU admissions and patients being kept for a long time. And there is no clear decision on whether we should get a DNR. And these things, I think somebody should step in and create real good algorithms, probably by using AI, and decide how long an individual should live. Thank you, sir.
Wow. No, it's wonderful. Dr. Bose, I just wanted to say something to you. I was really admired you. I think you're Dr. PS's son, I presume, right, sir? You were my PG, I remember when I was
Yes, sir.
rotating as
Yes,
a
sir.
medical student,
Yes,
and I
yes,
still really
yes.
admire the way you used to run our clinics, and thank you for that education.
Thank you,
And
sir.
regard Dr. PS as really thing, because thank you.
One of the quotes from Stoicism is that gods envy us because we are mortals.
Ah.
True.
But the
So,
question about the decision making for oncology patients, it was also true for people with severe neurological conditions. I worked briefly in
Very
London,
true.
in England for 5 years, and then there's a hospital called Royal Hospital for Neurodisability. It's now, I think, not there anymore. They changed the name. It is on Putney, and there this question arose about when do you stop something. There was a famous, she was an author. The son had traumatic brain injury, and he was functioning to a certain degree. And they used to live, I think, somewhere in the Caribbean. So they brought the son for respite care to England. And unfortunately, he had chickenpox and he developed seizures. On the way to the hospital, he developed anoxic brain damage on top of his traumatic brain damage. So he became a persistent vegetative state. So in one of the meetings, that the mom came and said, if you tell me that my son is not able to feel anything on a purposeful level, why are you doing anything to him? And that was mind-boggling, because the question arose is there's a huge difference between Dr. Sivakumar, you can say also, between persistent vegetative state and minimal awareness state. And the Royal Hospital of New Disability had a flagship in which NHS patients were sent for 8-week blocks in order to be diagnosed with persistent vegetative state, because the care which they got would be, tailored accordingly.
Yeah, we do refer to Patni, Syed sir. Yeah.
Oh, still?
Such
Okay.
patients. We do refer.
Dr.
It's still
Keith
there. Patni
Andrews
is
was
still
there.
there. Yeah.
And then the other question to answer to Dr. Bose was that when he said about oncology patients, now in US, that is the main problem, is you will see in the ICU 92-year-old, 93-year-old, 94-year-old who did not have a good, quality of life before. They'll be lying there with all the tubes attached, nobody there to make a decision except the family members.
Correct.
And sometimes there'll be a dispute between family members depending on multiple issues. So small example is money, as everybody knows, and who's to make a decision when. Whereas in England, I thought that was wonderfully done, especially in spinal cord injury. When Dr. Frankel was there, we used to have a meeting for high-risk patients way before the time came. And there's to be updated every year about the DNR status. And the patient had the ability to make a decision so that we're not left, at the end to give them a not so good farewell,
Yeah, and in England, I think still the case. I think we clinicians are responsible for those decisions, and because it's a state-funded system, everybody gets everything, and therefore we as clinicians are responsible for such decisions.
Captain, sir, any comments, sir?
So wonderful, wonderful. I am too old to wear the glove. Listening, keeping my brain active.
Thank you very much, sir. It's great to hear from you, and thanks for your attendance. Thank you very much. Yeah.
I am 77.
Yeah, I know. Thank you very much, sir. Great.
So, Dr. Sivakumar, your closing comments?
No, I think thank you very much for your engagement, and especially to you, Dr. Venkatesh, and Dr. Murali sir, and all the seniors who are behind this initiative. It's a great one, and thanks very much for managing these meetings as well and organizing these meetings. Despite being a nephrologist and being busy in Chennai, it's not an easy task, and it tells a lot about your appetite to help the next generation. And thanks to all of my seniors and Dr. Bose, and there are lots of seniors there. And thank you very much. I think it's always been a pleasure, to be associated with your alma mater. Although I've given talks in different places, London, Cambridge, and other places, but I think this has been quite an exciting experience for me. Thank you.
Thank you.
Thank you.
Thank you, Venkatesh. Thank you, everyone.
Thank you very much. Yeah,
Thank you, sir. Thank you.
Thank you. It was wonderful. Thank you.
Thank you, sir.
Thank you.
Thank you. Thanks, Venkatesh. Thank you. Bye-bye.